Well, welcome. I'll give you a couple of seconds to get situated in this. To make sure that you're in the right room, I was actually on an airline flight the other day, and they said, and had taken off, and the flight attendant came on and said, we just wanted to make sure that you were aware that you are on your flight to Charlotte, North Carolina. So I want to make sure that you guys know that the topic of this session is safety and independence, the Epilepsy Balancing Act. And the session is generously sponsored by the University of Michigan Health Systems. My name's Gary Ball, and I am the outreach coordinator for the Epilepsy Foundation of Michigan, and I'll be moderating the session. And let me introduce you to our panelist, Dr. Simon Glynn, who is an epileptologist on the adult side of the University of Michigan's Comprehensive Epilepsy Program. Dr. Renee Shellhaas, a pediatric epileptologist at the University of Michigan C.S. Mott Children's Hospital. And then Daniel and Andrew Quinn, who are going to share their personal perspectives related to the topic. As the title suggests, we'll be discussing some of the risks associated with epilepsy and how people with epilepsy, their family members, and health professionals can reduce these risks to promote safety without unnecessarily limiting your independence. So, Dr. Glynn, Dr. Shellhaas, and I'll let you guys determine who goes first. Give us briefly a description of your background, some of your clinical research. I think Dr. Shellhaas just won that. So, your clinical research interests and your clinical philosophy as it relates to the topic.
So, my name's Simon Glynn. I see adult patients with epilepsy for the most part at the University of Michigan. I have an interest in imaging in epilepsy as a tool to improve diagnosis, as a tool for surgical planning for epilepsy surgery, and as a tool to better understand epilepsy at a conceptual level and for purposes of research.
And I'm Renee Shellhaas. I am a pediatric epilepsy doctor. I mostly look after kids with seizures. And my research hats, I have many, including looking at newborns with seizures. We participate in a number of multi-center studies looking at infantile spasms and early onset epilepsies in preschool kids. We're also working on studies for older kids, looking at transition for teens as they get ready to enter Dr. Glynn's clinic. So that's me.
Daniel and Andrew, kind of introduce yourselves to the crowd and give us some initial thoughts on the topic as well.
Sure. Go ahead, Andrew. My name's Andrew Quinn. I was diagnosed with epilepsy when I was actually 18, so a little later on than just childhood. But I'm 25 now. Let's see, I had 2 resection surgeries done, and it's been about, going on 3 years since the last one. It's been seizure-free since then, so things have been going good.
Yeah, we're thankful for that. As far as the topic, I think that we can contribute a little bit because of our experiences with dealing with it. Andrew was diagnosed with epilepsy literally days before he was being sent off to school to start college. So imagine the angst of parents sending a child off that had just been diagnosed with epilepsy and having uncontrolled seizures. So safety is definitely a topic I think we can comment on.
Okay. Well, part of what we have to deal with people with epilepsy is to live both safely and independently, which sometimes can be a challenge. And it's important to understand what the risks are that are associated with epilepsy, how significant those risks can be, and how you can reduce those risks. And Dr. Glynn and Dr. Shellhaas, talk briefly about some of the short-term and long-term risks that are associated with anti-seizure medications and how you guys help your patients manage those risks.
So it's difficult. The starting point should be that the medicine is to help you. The starting point should be that a patient is seizure-free on a medicine with no side effects from the medicine. That's the starting point. That's not always something we can accomplish, but that is the starting point. Some of the older medicines have a side effect profile that it's important to review with patients. Some of the older medicines require periodic monitoring with laboratories and occasionally with other tests. Less commonly, some of the newer medicines require specific monitoring for concerns that have shown up in clinical use. But the point is to try and avoid all of those things. The point is that when you take the medicine, that you see that as a positive thing, that it's something that's helping you, and not that you're taking a medicine that's making you feel sick. So generally, medicines, all of the medicines can have non-specific, what we call neurocognitive side effects. So some of you will know what that means by taking medicines. Some of you will know what that means if you've ever had too much to drink. It's a clouding of your thinking, it's an unsteadiness, it's a slowing, it's a dizziness. Those are non-specific, meaning they can be seen with almost any medicine, and it's often a dose-dependent effect. Some of the older medicines are metabolized in a way that complicates their use, and it complicates the use of other medicines. And usually those medicines also require that some laboratories be done periodically to be certain that those medicines aren't affecting blood counts and that they're not affecting the liver. The newer medicines, that tends not to be done. And of course, you counsel each patient on the specifics of the medicine that you're proposing that they take. Clinical trials data is available for all the medicines. And it is a guide that we use to counsel patients about what to expect on a medicine, but it's difficult in two respects. The first is that the clinical trials data comes from giving this medicine to people that are already on several other medicines, and then asking them how they feel, recording whether anything adverse happened. That often is not the scenario for a person starting their first medicine. It's a different context. The second is that the clinical trials data is only a guideline. It doesn't say what will happen to you with the medicine. And really that's, of course, what you want to know. So if you're unfortunate and you're one of the people that has a side effect seen in only 3% of people on the drug, it doesn't really matter that it's seen only in 3% of the people. It's a side effect you have, and it's not the right drug for you to take.
Well, personally, let's see, I've been, 5, 6, 7 different medications, so completely agree with that. We had to go back and forth. We did have some, dizziness or with some. So you just, it's not a great term to use, but a trial and error, I suppose.
Yeah, exactly. And it can be a frustrating process as well, because you want to get to that therapeutic level that's the right level that's going to hopefully control those seizures without going beyond it to where you're in a drunken state. There was one medication, I can't think of the name.
What was it, I think Topamax?
Topamax, and I don't want to single out drugs because it may be a good drug for some, but not for others. But in Andrew's case, it made him just like a drunken sailor. He was just not himself. He was just totally personality change, and it didn't work for us at all. So we went right back to the neurologist and said, we've got to make a change. And right away made that change and tried other medications. So.
And what I'm hearing from all of you too, and I think one of the keys to it in terms of the risk factor is talk to your doctors.
Exactly.
Let them know what's going on.
Absolutely.
Or as parents of a...
Right, so absolutely, you did exactly the right thing. My kid isn't himself. I need to know that, because my starting point is most kids will tolerate a medicine just fine without significant side effects from almost every medicine if we start it slow. And so I can't tell ahead of time whether it's going to be a more or less effective medicine in many cases. So I need to hear back from the parents of my patients that say, you know, he's just not right, or there's something else going on. Could it be related to the medicine? Sometimes they say, you know, there's no way this particular thing is, but sometimes I've been wrong when I've said that. So if your gut is this medicine isn't the right thing for me or for my child, then your doctor needs to hear it.
Okay. That's on the medication side in terms of the risk.
Actually, I want to just
Okay.
interrupt and say two more things. The first is that's very frustrating for patients when we prescribe a medicine and the medicine makes you sick. That was never our intent, but it is also frustrating for us. It's very frustrating to have to choose from, depending on the type of epilepsy you have, maybe 20 different medicines, and not be able to tell you as a patient that this is the right medicine for you and this is the right dose. And I can't do that. And it's frustrating for us. It's not a problem that's being ignored. It just, there haven't been the tools to address it in a sophisticated way until recently. So there are actually projects now underway to try and find biomarkers, so a blood test, if you will, that might, at least for some medicines and some types of epilepsy, be able to predict whether you would be a person that would have a side effect or whether this medicine might be effective for you. There are a few that have popped up, a few contraindications, a few specific tests that we can do to make really worrying side effects, to exclude those, to make those less likely. But we still do not yet have what we ought to have, which is a way of testing you and telling you that one of these 3 drugs will be the right drug.
Okay, thank you. The most obvious risks associated with epilepsy are those related to seizures. In your practices, what are some of the most common injuries that you see in patients with epilepsy? And what can you do, and what can be done to prevent or to lessen the severity of those?
So I'll talk first, and then I'd love to hear your perspective on that. And I apologize if you guys can't hear me when I talk, because I know my voice gets soft. Just wave or jump up and down, and I'll try to do better. So I look after mostly kids, and most of the patients that I look after do not have injuries related to their seizures, right? The ones who do generally are the kids who have drop seizures, where all of a sudden, without any warning, they fall and maybe hit their face on a table or knock their head against a corner or something like that. And so if I'm going to see injuries, it's usually from those kids who fall and have no warning that they're about to fall. And then it's cuts and stitches and knocked teeth and noses, that kind of thing. But the vast majority of my patients don't have injuries related to their seizures, either because they have seizures that aren't putting them in harm's way or because they have appropriate safety plans in place so that they're not going to get burned or get in the tub and not be supervised and that kind of thing, so we can prevent most injuries. So for the most part, that's not a huge piece, although it certainly can be for some patients. Will come in and say, you know what, look at my child's face, and this is an indication to us that we need to be more aggressive with medicines or we need a new plan, that kind of thing. But for most kids, they need to go about daily life just like they did before, with just a few extra precautions in place. So we can talk about some of those when we're ready, but I don't know if you have any questions that you or comments that you might have.
Did you want to comment? Or?
Well, I mean, just me personally, I don't think I ever had any big accidents
No,
or
no.
injuries, but I think a big reason that I never did have that is just because we were pretty good about everyone knowing that it possibly could happen and what to do if something did happen. You know, if I did go into a seizure, everyone knew, you know, what to do, to kind of just lay me down. I'll get through it. And we tried not to put ourselves in situations where something bad could happen.
Right. In his case, fortunately, you know, he didn't suffer any injuries because of, during seizures, because he would kind of go into this suspended state of animation, if you will. He didn't have a drop seizure like you talked about, where he would just lose his physical ability to stay put. One time he was out in the yard holding the rake. It was this time of the year. He was holding the rake, raking leaves, and I looked out, and you were like a statue. So we were fortunate that you didn't have those drops. So we didn't experience those type of injuries that you mentioned.
Dr. Glynn, you want?
So seizures, of course, do cause injuries. You can see shoulder dislocations. You can see rib fractures as people get older. Not in children. Often their bone health is less good. You can see compression fractures, vertebral compression fractures if someone has a large convulsive seizure. Drop attacks that Renee is talking about, the physics of getting older make those more dangerous for you. So if you tend to fall without warning, your injuries will be less when you're 3 feet tall than when you're 6 feet tall. Those are all things that are very hard to modify, except by minimizing or completely stopping the person having seizures. The other risk is circumstances, and that is completely in a person's control. So clearly, depending on your circumstances, you may be at increased risk if you have a seizure. If you are on a ladder and you have a seizure, the consequences will be different than if you're lying in bed. If you are swimming in the ocean alone, the consequences will probably be fatal. If you are parachute jumping, the consequences would probably be fatal. So circumstances lead to injuries. We worry a lot about circumstances and how to modify those. And that's a source of injury that is in control. And then something that you didn't ask, but a question that often is unasked, but people are worrying about is a brain injury. Does a seizure cause a brain injury? And that's a very difficult question to answer because the answer is complicated and because there are quite a few unknowns. But the simple, direct answer is we do not think of a typical single seizure or small number of seizures as causing a brain injury. And if you find that difficult to believe, recognize that a common diagnostic test we do is to bring people into hospital, take away medicines, and record them having seizures. So that unspoken concern should be put aside for most people. A seizure does not result in a brain injury.
Thank you. You had mentioned skydiving and swimming in the ocean and those kind of, I mean, those are obviously high risk. Did you want to add to that, Dr.?
So I get these kinds of questions all the time. You know, my 6-year-old has epilepsy, and what restrictions are there on his participation in sports? The answer is no. That 6-year-old should participate in all the age-appropriate childhood activities that there are. So there, for example, is no contraindication, meaning you can't say, no, this kid can't participate in contact sports. You know, my kid, I don't let him do football because I don't think it's the right choice for our family. But that doesn't mean it can't be the right choice for a different family. As long as there's, you know, common sense in place, kids especially should be expected and allowed to participate in all of the age-appropriate activities that are available to them. Common sense things. If there's a helmet associated with a sport, then the kid needs to wear the helmet every time. And so does his brother, and so does his mom, and all that kind of stuff. So I go through that. If you come and see me in my office, I will ask your child what color their bike helmet is, and I will expect to hear an answer right away. But they should be permitted and encouraged to participate in sports. We see a lot of times that families get worried and they try to restrict what physical activities their kids are participating in, and that's not in their best interest. Things that we get serious about, water safety. It doesn't take a lot of water to drown, and so I take that very seriously. That's where there's a restriction. You don't get to take a bath in a tub unsupervised if you're at risk for seizures, right? You can take a shower, keep the door unlocked in the bathroom, turn the hot water temperature down enough so that if you knock the dial and it goes all the way to hot, you're not going to get scalded. But you can do that. If you go swimming, there needs to be somebody whose job it is to watch you in the water and who would be able to take you out of the water, heaven forbid you have a seizure in the water, right? So little old grandma sitting in her wheelchair at the side of the pool is probably not the right person. Similarly, the lifeguard at the pool has too many things to do, and that's not the right person either. And if it's everybody's job, then it's nobody's job to watch your child. So there needs to be somebody assigned to watch my kid when they're in the water. But that doesn't mean my kid can't go to swimming class or anything like that. So overall, kids need to be encouraged to participate. If you need empowerment to go to your school and say, no, it's really okay for him to be in sports, if you go on epilepsy.com, they have some nice printouts that you can get that say it's okay to participate. So.
I was just wondering with Daniel and Andrew, have you guys had any of these discussions on, what kind of activities and
Absolutely.
what to do and not to do, and how did you as parents and then how do you react to that?
Sure, yeah.
Yeah, absolutely. I mean, like I said, I wasn't diagnosed until I was 18, and going through high school, I played, sports all year long, and so
Swimming.
yeah, and swam. So when it did happen, yes, there was quite a few discussions, and it was pretty much like you were saying. It was just decided upon that if I was going to participate in these sports, we needed to be in a situation where someone was there that if something were to happen, they knew what to do. And we just avoided putting ourselves in situations where if something did happen, there wouldn't be anyone there.
Right. We kind of avoided swimming right from the onset because, like you said, it doesn't take much water to drown. So we kind of avoided that right off the bat. But, as a family, we love to ski. And we thought, well, we're not going to let this stop us. So we continued to downhill ski for the first year or so. And there weren't a whole lot of grand malls at that time. It was a lot of partial seizures, very frequent partial seizures. And when we had a discussion with our neurologist about it, he seemed a little alarmed. He says, yeah, you might want to open that up for discussion. And then as the grand malls started to progress, we did have to make a decision to stop that activity. It was a difficult decision because it was something that we really loved to do as a family, and so we had to find alternatives. So I think, like the doctor said, you have to decide as a family how you're going to handle it. What's good for one person may not be good for another. So you got to look at your situation, I think.
Okay. Well, the next item that I have
on
my guide is...
run right over
Yes,
you, Jerry, and say...
I'm glad he interrupts.
So I don't know who your doctor was that said that.
Yeah.
That's the approach that I think Renee and I quite like. So in another time, in another place, we are very paternalistic. We tell you what to do. That's really no longer the case. and everyone in this room is going to have a different level of anxiety about what might happen related to seizures and a different level of passion for some activities that they think are important to them. And you have to think about it.
Yep.
And our job is to inform you about what those risks are, and make sure that you and we aren't being stupid about things. The second thing I want to say is that Dr. Shellhaus has children that play hockey, so don't think she wraps them in cotton wool and puts them to bed at night.
In fact, they have a helmet for every sport that they play, and they wear them every time. So, yes, they do, in fact, play hockey with a helmet.
And the last would be that there are two variables that you're trying to take into account. The first is what your risk is that you will have a seizure, and the second is what are the consequences that something bad will happen if you have a seizure in that circumstance. So you may be someone who's not had a seizure in 2 years' time. Scuba diving probably still is an unreasonable decision for you to make, because if you are unfortunate and have a seizure in that context, the outcome's certain, right? Conversely, if you have very frequent seizures, seizures are not yet controlled, but you're optimistic your doctor will get them under control, then you may need to modify some really day-to-day activities. If you work at McDonald's, you would not want to be on a deep fry station until your seizures are under control.
Okay. The next question that I have is one that actually it seems like not a week goes by that I don't talk to somebody, and in fact, out during the break it happened. Regulation in Michigan is pretty straightforward about driving. You can't drive if you've had any type of seizure in the last 6 months. And every state in the union has some kind of restriction on that. But when you consider driving on a case-by-case basis, there's a lot more gray areas than just what the law says. So talk to me a little bit about exceptions to the regulation, or how you deal with that, because, and obviously with you guys too, how you dealt with that, and from a medical perspective, how do you deal with the driving question?
Can I ask how you were counseled?
Well, I had my first seizure while I was driving. I was lucky enough that it was in a parking lot, and somehow I managed to park the car. I was going to pick someone up from the store, and they realized that I hadn't walked out to meet them for about 5 minutes. So they were quite confused, so they came out to the vehicle and saw what was happening. But because that happened, I had lost my license at that time, and it was like you'd said, the 6 months. It did take until, after I had my second surgery, 4 or 5 years later, we did have to wait that I think we waited 6 months to almost a year before we did talk to my doctor and decided on that it was appropriate for me to go ahead and get my license back.
And the way the Michigan law states is you have to be 6 months seizure-free. And if you have any type of frequency of seizures, even if it's partial, I believe you're supposed to, stay off the road. So it's a tough thing, and people have to get to work or to have to drive and that. I don't know how you deal with that on a day-to-day basis. We were fortunate enough that he was just a young adult. We could taxi him around. Transportation was not an issue.
Right.
So he didn't drive from that point. That was 2006, fall of 2006, till just recently got his license back. So he didn't drive at all.
Right, so this is a balance between autonomy, personal autonomy, and public safety, right? The law is what the law is, and that's not something that I'm gonna play with, right? It says you have to be seizure-free 6 months, and I don't tell anybody there's an exception. I also don't get to make the decision, right? Michigan is not a mandated reporting state for doctors. And in some ways that's good because it means that my patients who are teens are more likely to tell me if they have a seizure and not keep that a secret from me because they're worried they're going to lose their license. But the law is the law, and it means that you don't drive in a parking lot, and you don't drive in the driveway, and you don't practice with mom. You don't get behind the wheel. You don't want to run somebody over. If you're, driving at 70 miles an hour and you have a 3-second seizure, you can go, a football field length before you come back. That's a long way to go, and you're putting your life at risk. For my middle school age kids, I try very hard to say, okay, is there a chance that you have outgrown your seizures? Is there an opportunity here to get you off of seizure medicine safely before you hit that 15 and 16 years of age, to give you the best shot at just learning to drive like everybody else and continuing on with your license. And I try, if we can, to wean meds at 13 and 14 years old, so heaven forbid again, if the seizures come back, we have enough time to get back in control when they're 15 and 16 and doing driver's ed with everybody else.
So the restriction in Michigan is 6 months. Every state has its own restriction. It varies from 3 months to, there used to be 2 states that had a 2-year restriction. I think it's a 1-year restriction now. Most states are 6 months. 4 states are 3 months. Some states have mandatory reporting, which means that when you tell your physician you've had a seizure, your physician has to fax a form through to the DMV informing them. Michigan is not a state that has that. We're required to tell you what the law is about driving. We don't interpret the law for you. The restriction on driving, by the way, just to be clear, doesn't say what kind of seizure. It doesn't even say seizure. It lists seizure as in a long list of things that would prevent you from driving. So excessive daytime sleepiness, a diabetic that's poorly controlled, someone who has non-epileptic events that impair their ability to communicate or control themselves. All those things the restriction applies to. And it's worth understanding, though, that that 6 months and 3 months are chosen for a reason. As you can guess, there have been studies done that show that if you are seizure-free at 6 months, you are unlikely to have subsequent seizures. The risk is not 0, but the risk is low enough that the state has decided that you can drive. And that risk is a front-loaded risk. That's why in a few states they have a 3-month restriction, because most of the risk for a second seizure or a relapse seizure is in the first 3 months. So we've been speaking very negatively about this, but if your risk, if you pass that 6-month threshold and you are cleared by your doctor to drive, what is your risk? So that's been studied. In patients that have epilepsy, 90% of the accidents they're in are not because of seizures. 10% of the accidents that a person with epilepsy has are related to seizures, only 10%. What's your risk relative to other people? Well, they don't actually, the federal government doesn't report data for seizures specifically, but they do report it for loss of consciousness. So presumably seizures is embedded in that risk. 0.7% of accidents are caused by loss of consciousness. 34% are caused by drunk driving. Your relative risk of having an accident if you have epilepsy is the same as a driver who is under the age of 25. Your relative risk is the same as a male driver under the age of 27, I think. It's a very small risk. So if you're cleared to drive, you're cleared to drive. And if the state is going to clear you to drive a 2-ton vehicle down public roads past bus stops full of children, then clearly the constraints on what you can do in your life have been relaxed, right? So it's hard to say to someone, well, you really shouldn't be cooking for yourself, but it's okay to drive your Cadillac. It's just not sensible.
You have a question over here.
Yeah. The driving restrictions, does that mean golf carts on like a golf course or golf carts anywhere? Like a city public driveway?
Yeah. So that's I don't. Two things. I don't know the answer. First, and second, law enforcement has lately been cleverly applying vehicle code laws to mopeds and bicycles. So lots of kids are getting tickets on bicycles for not obeying vehicle code regulations. I would assume you have to be on a public road for those rules to apply. So a golf course probably is fine. A golf cart is probably fine. It's worth, though, as an individual, thinking about the fact that if you're not safe to drive a motor vehicle on public roads, is it sensible for you to be driving any kind of motorized vehicle on private roads?
Yeah, I was just going to add, I always was the first one to grab the driver's seat in the golf course.
Yeah, well, the reason I asked is because I have not been seizure-free for over 10 years, and I thought, okay, you can do that versus driving a 32-ton vehicle. That way you can take your feet off the gas.
Yeah, I think you have to, I'm sorry, assess your risk with yourself and your neurologist. I think you two have to decide what your risk level is.
Yeah, my only statement is there are water hazards and sand hazards on the golf course as well. And if I may, for the benefit of everyone in the room, and thank you for your interaction, we are hoping to get a Q&A session in. So if we can do that, that'll be good. And I know driving is a big issue among everyone. It's one we could probably spend a lot more time discussing and talking about. But moving to a little bit, I guess, deeper subject, a couple of them, Statusepilepticus. Prolonged seizure activity, for those of you that may know, can lead to brain injury, potentially can lead to death. And I wonder if our panel, Dr. Glynn, Dr. Shellhaas, can you talk a little bit about the preventable causes of Statusepilepticus in people with epilepsy first, and then also talk about the rescue medications used in like non-clinical settings and how and when they should be used?
Sure. So it's not good to have long seizures, right? We can all agree on that. For people with epilepsy, Statusepilepticus would be a very rare cause for death. Most people who have epilepsy and present with long seizures, they have long seizures and it's annoying and they end up in the hospital and they get sick, but they mostly don't die, right? And they mostly come out of it okay. And if we look at kids who were healthy before they had their Statusepilepticus, and we look at them later, they're the same kids as they were before, okay? But it's not good for you, in general, to end up with a really long seizure. The most common reason for a person with epilepsy to have Statusepilepticus is to not take their medicine. Completely in your control. So that, that's the good news, it's in your control. For my young patients who go off to college or in high school and they try to experiment with life, alcohol, illicit drugs, stress, sleep deprivation, and oh, by the way, I didn't take my medicine when I came home at 7 o'clock in the morning, having been out partying all night. Again, it's in your control. It's a choice you can make, and that's the good news. You've got to take your medicine, right? For people who have a risk for having clusters of seizures, a seizure back to back or prolonged seizures, it is always a good idea to have an action plan that you've worked out with your doctor. And there are a number of different choices for medicines that can be given at home, at school, wherever. Those will depend on your circumstance. So for a young toddler who may have frequent seizures, we will usually prescribe rectal medicine, Diastat, because we know what dose to give, we know it's safe if we give it at that dose. Although it's expensive, insurance companies will pay for it. It's prepared in a way that is not hard to carry around in your purse, kind of thing. For an older kid, having a rectal medicine, or an adult, is not socially acceptable. It's also difficult to give, right? And so we need to think about other plans. There are some other choices. Luckily, we're getting more and more choices, and I think over the next few years there will be additional choices. So it's worth revisiting if you don't love your action plan, revisiting with your doctor when you see them. Is there anything new? Do you have any other ideas? So there are wafers of clonazepam that can be given in the mouth that will dissolve. There is an intranasal spray of midazolam that can be given. There is a liquid form that can be given in the cheek. So it depends on your circumstance. When to give it also will depend on circumstance. So I have some kids who we say, do not give the medicine, the rescue medicine, until a seizure's gone on for 5 minutes. And 5 minutes, as you probably know, it's a really long time. So it takes looking at your watch, looking at your phone, figuring out exactly when did this seizure start. Usually I will counsel parents, if you look at your watch and at 3 minutes, that seizure doesn't look like it's stopping anytime soon, go and get your Diastat, get ready. If it's still going on when you're ready to administer, go ahead and give the medicine. I have other patients who every time they may not have seizures very often, but whenever they do, it's always a long seizure. And for some of those families, we just give the medicine, the rescue medicine, immediately once the seizure is recognized. So it depends, again, on individual circumstance, but I think what's most important is knowing what kind of seizure you have, what kind of pattern of seizures you have, and talk with the doctor about what would be the right rescue medicine for me to prevent a long seizure, prevent me from having to go to the emergency room or being admitted to the hospital.
I would say only a few other things. The cause of status epilepticus matters tremendously. So for most people who have a diagnosis of epilepsy, status epilepticus, I agree, it's not a lethal condition. It's something that is hard to manage, but it can be managed. If you read about status epilepticus, if you go online, you're going to see horrific numbers. But understand that those numbers will include people that have had a traumatic head injury from a car accident, that have a brain tumor, that have some horrific underlying illness, and status epilepticus is a symptom of that. The second thing is that timing is important. So seizures are easier to control early on. They become progressively harder to control as time passes. The third point is that if you see someone being managed for status epilepticus, or if you are being managed for status epilepticus, your medical team should explain this to you, but most of the decisions that are being made are because of the medicines being used. So it is true that if someone is left in status epilepticus for a long period of time, they'll need support systems. They'll need things to support different systems in their body. But usually what causes you to be put on a ventilator, what causes decisions to be made quickly, is that we just want to escalate care. We want to use medicines to stop the seizures. And we have medicines that will stop seizures in everyone. But those medicines will usually suppress you to the point where you can't breathe for yourself. So many of the decisions that are being made are not because you're in a physiologic crisis. It's that we've elected to use the next medicine, and we simply need to protect you while we do that.
I think we're back on. SUDEP, the sudden unexplained death in epilepsy, has recently become a major topic of discussion in the epilepsy community. Can you give us an overview of SUDEP?
Who's doing that?
Rock, paper, scissors.
I know that was a deep one that you'll...
Dr. Shellhaus wants to tell you that this is less common in children than in adults, and for that reason, I should be speaking to it. That's correct. So SUDEP is uncommon in most people with epilepsy, and it's very difficult to talk about. So, for those two reasons, many of us are reluctant to talk about it. And so at a professional level, at a national and international level, there's a lot of education going on to try and encourage people to talk about this. In part because studies have shown that you want us to tell you about it. We are anxious about how you'll react when we start talking about something like that. We think probably it's better that you don't know. And you are telling us otherwise. So there's an effort to encourage people who see epilepsy patients to start talking more openly about this. SUDEP, sudden unexplained death in epilepsy, probably is because someone has a seizure and either stops breathing or develops a cardiac rhythm problem and dies. Very infrequent in people with epilepsy, maybe 1 in 1,000. Maybe 1 in 1,000. In people that have medically refractory epilepsy, in people that are being evaluated at surgical centers, in people that are failing multiple trials of medicines, that risk is higher. In people that have convulsive seizures, that risk is higher. In people that have seizures at night when they're asleep, that risk is higher. How high your risk is sort of a, I don't know that it's helpful to say that to a group of patients. I don't know, and their families. But the risk ranges are probably 1 in 200 at the high end and 1 in 2,000 at the low end. Some of that risk, why are we reluctant to talk about it? Well, because we're trying to stop you having seizures, right? We're doing everything we can to prevent seizures. So in a sense, we feel a little hostage to fate. We're counseling you about something that we can't really do anything about. I think it's important if someone has a profile that puts them at higher risk, that be discussed early and openly. There are some things that are in a person's control to minimize that risk. So not missing doses of medicines is in your control. Creating some sort of monitoring system at night is in a person's control. And considering more aggressive treatments is in your control. So many people are scared, many doctors are scared to refer people for epilepsy surgery. Many patients are scared by the idea of it. For someone with refractory epilepsy, the risk is pretty much a wash. The risk of doing the surgery is about the same as the risk that something bad will happen if you don't do surgery. And those things are important to talk to people about.
What do you think about, as a family, about discussion about SUDEP?
You're right. It's not something you want to talk about. And early on, when Andrew was diagnosed with epilepsy, I'm one of those people that just have to scour the internet, and I caution you on information from the internet, but websites like epilepsy.com, there's some really good information out there. So I read up as much as I could to learn about epilepsy, and that was the most alarming one that came up, that SUDEP. But we did have some discussions about it, not much. I think primarily because of, like you said, the risk is very minimal, very low, that something like that would happen, but it does exist. And so as far as thoughts on it, we didn't talk about it. It exists, but it's a tough subject, really.
And to put it in perspective, I mean, the person at last year's national meeting international meeting for epileptologists who stood up and gave a platform presentation on SUDEP, the risks and how to counsel patients. I mean, he was one of my mentors less than 10 years ago and didn't counsel his patients about those risks. So it's something that we're trying to quickly come up to speed on. as a profession.
And it's tricky for a pediatric epilepsy doctor. The risk for kids is extremely low, not zero, and there are some cases where we definitely need to be talking about it as we think about the risks of escalating treatment or of not treating certain kinds of seizures and that sort of thing. But for most childhood epilepsy syndromes, those kids do well anyway, and their risk is exceedingly low. It's hard to discuss risk though, right? If it's a 1 in a million chance and you happen to be the one, it doesn't matter about the rest of the people. So it's, if your doctor hasn't brought it up and you have questions and want to talk about it, then you should do that and ask them, can you please talk to me about this and give me some information? It may be that they don't want to scare you, and maybe that it's not that they're trying to withhold information, but they're not sure exactly what your desires are about talking about scary topics.
Okay. One last small thing to discuss, and I don't know how many of you in here have family members with epilepsy who are kind of transitioning from adolescence into that adulthood and independence, which for some of you can start at 8. But talk a little bit, especially Daniel and Andrew, because you guys have kind of been through this transition here recently. How do you make a transition from that adolescence and into some more independence? And how do you do that transition successfully?
Well, it's, I was diagnosed when I was 18, so I wasn't, I was out of school, so we didn't really have to deal with that. Well, I should say I was out of high school, but did wind up going to college. It was kind of difficult being an hour and a half away, because it was kind of a huge step into adulthood, but we handled it just by, we stayed in touch quite a bit.
Communication and preparedness. We just made sure that everyone you were associated with, involved with, roommates, professors, whatnot, know your situation, that you could have a seizure at any time. So just trying to be prepared, I think, was the most important thing for us. Because how else do you deal with it? That's all you can do, is try to be as prepared as possible.
Right, and just make sure that everyone that you are around does know that, something could happen, because that's all you can do.
So this is something that I obviously deal with a lot, and it is never too early to think about transition plans. I start really early, depending on how the patient is functioning, how the child is. So if I have a kid who's in regular school, we fully anticipate this kid's going to graduate from high school, go to college, be an independent person, then by the time they're 8 and 9 years old, when they come to see me in the office, I'm going to ask them, what is your medicine? How many pills do you take? How many milligrams does that make? And I'm going to expect you to know that. And then when they start to be 10 and 11, I'm going to say, when it's time to refill your prescription, I want you to make the phone call to the pharmacy and start to gradually take steps towards independence as is age appropriate for that child. So that, and then, as time goes on, more and more independent talking directly with the child. Mom and dad can be in the room, but the child needs to be able to give their story, know their epilepsy, know their seizure type, know their medicines, and that kind of thing, so that they're prepared to go off to college and meet the doctor at, University of Michigan Student Health Service and be able to give their history. I tell them, heaven forbid you fall and break your arm and ended up in an emergency room, and it's going to be, 2 hours before mom gets there. You need to be able to tell the doctor in the ER, I have epilepsy and I take this drug and I'm due for this dose now, right? The last thing you need if you break your arm is to have a seizure because you missed your medicine, right? So it's never too soon to start to gain that independence. Now, for other people, it's not realistic to say they're going to learn all of their medicines and be independent in the long run. We need to think early about what kind of education settings we need to be in. Is this somebody who needs life skills training and planning for living in a group home or that kind of thing? Or are we talking about somebody who needs total care all of the time and planning to transition to adult care, an adult clinic, and go and see Dr. Glynn instead of Dr. Shellhaas? But we need to make sure that issues of power of attorney and that sort of thing are worked out ahead of time. But the bottom line is thinking about that well before somebody turns 16, 17, 18 is critical, because it's not something that happens with the flip of a switch.
Coming to see me is terrifying, and I like them to be well prepared by Dr. Shellhouse, and always are.
I would also give a plug if you are a family with a child, a teen, a middle schooler, or high schooler with epilepsy. We have a program that we're developing in conjunction with Epilepsy Michigan. That's a day-long program for teens and a separate one for their parents to talk about seizures and epilepsy and independence and transition to adult care. So you can call Epilepsy Michigan and get information about that. I think it's going to be a great program.
Let me just ask our panel for time. Being the issue, are you guys going to be around for a little bit after this and for the evening? So if you have questions for our panelists, if you want to try to track them down afterwards, I'm sure they would be more than happy to spend some time answering your specific questions. Thank you, Dr. Glynn, Dr. Shellhaas, Daniel, Andrew. Thank you for joining us today. And for the safety and independence session for this conference, giving us insight into a very complex topic of the Epilepsy Balancing Act. And also thank you to the University of Michigan Health System for sponsoring this session.